Everyone, and welcome to Cardiac Science Grand Rounds for, what is it, April 23rd? Today, we have our surgical colleagues joining us. Dr. Adams and Dr. Kent are going to speak on minimally invasive mitral valve interventions. As many of you know, we're working towards a kind of more integrated mitral valve and structural heart program here in Calgary. We've seen talks over the winter and spring from some echocardiographers, from Nish Sharma on the interventional side, and now we're going to talk to the surgeons about what's new and what's possible for us to do in the area of mitral valve and valve surgery in general. So Dr. Adams, Dr. Kent, I look forward to your talk. Thanks.
Thank you. Thanks, Andrew. I think that introduction was exactly what we want to touch on. And we want to build a real collaborative group, and I think that should be the focus and is the focus going forward for our group here. We've got some great teamwork that we want to highlight. So let's start. So I'm going to do the first part. We're going to talk about our minimally invasive mitral interventions program, touch on our vision, show you some of our new technologies, what we've accomplished thus far, how it's benefited, impacted our patients here in Calgary and our group as a whole. Corey's going to talk a bit about our Calgary outcomes and some of the research that we're quite proud of, and it's in its infancy, I think, but has great potential, and then a vision for the future as well. So, you know, our vision is to establish an internationally acclaimed heart valve center of excellence in Calgary, and I think, you know, sometimes we have underachieved in the past potentially, and I think we have tons and tons of potential. You know, how do we get there? Well, you know, it starts with clinical, and it really always starts with clinical, right? This is the job that we've trained to do, and our clinical work is what really puts us on the map first and foremost, and everything else follows from that, I think. So establishing excellence in clinical outcomes. Now, there's a list of Newsweek, and in the US, you know, where, you know, Cleveland Clinic, you see at the top of that, Mayo Clinic, and you're striving to be, we're not suggesting we want to be on the Newsweek ledger, but, you know, I think some of these centers, we don't realize sometimes that we are very high volume here in Calgary, and our volumes at 1,800 cases a year in cardiac surgery rival many of the centers that are on this list. In fact, eclipse many of them. And so we have to realize what we have and what the potential is here in Calgary. So we want to provide state-of-the-art care with the latest technology. We want to attract the best talent and build the best teams. So let's talk specifically about valve surgery in Calgary. You know, minimally invasive is a program that was established in 2012 and has grown substantially. And now for isolated valve surgery, eclipses sternotomy for valve approaches, and we do 416 annual minimally invasive cases. Now that includes both mitral and aortic. So it's high volume, and I think one of the highest volume centers in North America without question. We have now 5 surgeons doing minimally invasive cardiac surgery. So we have a diverse group of both experienced surgeons and young surgeons, and we want to build that. We want to build that as a focus of you know, particular interest within our division. So just so you guys know, like what we're offering right now, and many of you know this, but it's good to highlight it. So MidCab recently started, and Dan Holloway has been leading that. Ganesh is playing a prominent role, and also Holly Smith is going to become involved in MidCab. So that's minimally invasive direct coronary bypass surgery. Corey and I specialize in minimally invasive mitral interventions, both mitral valve and tricuspid repair and replace. We also recently have started doing double valve replacement via third interspace mini thoracotomy. So that's something we're growing the program into that area as well. Aortic valve replacement. You know, you may not know this, but we do a lot of right anterior mini thoracotomy aortic valve replacement here in Calgary. If you look at the STS database, isolated AVR in North America, there's only 7% of patients that get this approach done. So it's something that a bit unique to Calgary, that we provide this in such volumes. We also resect cardiac tumors through a minimally invasive approach. And a bit of a niche procedure here, but beating heart, TAVI valve, and mitral annular calcification for these tough patients that many of us have seen and understand. So I'm going to run through, sort of give you a little bit of background about our minimally invasive approaches, and then we're as I said, we're going to look at the research and then go to the future. So looking first at minimally invasive mitral surgery, I think it's really important whenever we talk about minimally invasive surgery to contrast that with sternotomy. I'm not saying sternotomy is not a great approach, and I talked to a guy yesterday who said, you know what, the pain was like surprisingly minimal after sternotomy, and that's actually true. I mean, still the majority of our cases are done through sternotomy, but the recovery can be enhanced when you don't have a breastbone that you need to heal. So I think turning to a minimally invasive approach, we started that in 2012. Over 1,000 cases to date, and it has grown through the years. We didn't do the volume in 2012 that we do now, for sure. We're 180 cases per year, isolated mitral, done through a minimally invasive approach. So that's the 5-centimeter mini thoracotomy on a patient that was done recently. Here's what it looks like intraoperatively. So small incision in the side. It's actually, up near the anterior axillary line. A camera is put in the second or third interspace, and then the mini thoracotomy is third or fourth interspace. The operation, of course, is when you're working through such a small incision, it's done with specialized instruments. So these are long instruments and a specialized retractor. This is not robotic. People often think, is this like robotic surgery? No, this is specialized long shafted instruments through camera aided mini thoracotomy. So to show you the exposure, now part of the reason to do minimally invasive approaches to facilitate a quicker recovery, but also it's exposure to the valve. And this is the kind of view we get of the valve. It's good for you guys to see this and understand what we get. This is a way of exposing the subvalvular apparatus. Since we are Calgary with budget conscious management staff, we use a rolled up ruler to expose there are specialized instruments that are used for this, but of course we're trying to save the hospital some money. So it does work reasonably well that way. This is a repair done with neocords. I mean, it's a very anatomic repair. The other conventional way to do repairs is to resect a portion of the posterior leaflet. But I think we've learned over the years that this preserves tissue that really is healthy tissue, and we're supplying support to the prolapsing or flail segment. A lot of the art to this is, seeing the valve and deciding on whether you need to do a resection or a neocord technique, if you need to close the commissures, and then adjusting the length of the neocord. So there's a lot of nuances to it. Sometimes you read an OR report and it sounds like we're doing the same thing every time. Well, there's a lot of subtleties to it intraoperatively. So there's the simple neocordal repair. That's as simple as it gets, but that sort of demonstrates in a so that whole thing would take, probably 60 to 80 minutes of cross clamp to do all that. I brought that down to 2 minutes. Now that was one end of the spectrum. That's like the simple kind of repair. Now here's the other end of the spectrum, and this is, oh no, it's actually wrong here. This is the other end of the spectrum. So this is a more, complex thing that we do with the minimally invasive approach, and this is addressing those patients with severe circumferential MAC. Now, often the problem with these patients is, they're very high risk for removing all that mitral annular calcification. So if you remove a lot of that posteriorly, then you put the patient at risk for groove disruption, and you're exposing them to maybe a perioperative mortality rate approaching 20%. So this is a way of leaving the MAC in situ and placing a TAVI valve inside the circumferential MAC. And so we put a ring of felt around the TAVI valve. We crimp it down in standard fashion. That felt helps to, seat the valve into that rocky calcified annulus, and it's delivered through the incision. Now, often these patients have a lot of disease of the aorta as well. So we've done a lot of cases like this where the heart is left beating. In this particular case, we're unable to cross-clamp the aorta because it was porcelain. So avoiding the risk of stroke and placing the valve inside the MAC was, certainly a real reasonable option for this patient. So that's sort of the summary of the range of minimally invasive approaches that we have. Now, turning to results. So this is looking at STS database. What's the perioperative mortality for average risk patients undergoing mitral valve repair? So, and this is registry data. So 0.43% perioperative risk of mortality for isolated mitral valve repair in average risk patients. So we're doing a pretty darn good job of providing, a durable repair to patients at minimal risk. And speaking of durability, this is one series out of many, looking 20 years out at how durable are repairs. A 4.6% rate of reoperation for mitral repair at 20 years. This is from Toronto, 1,200 or more cases from Tyrone David. So certainly durable and safe perioperatively. At Foothills, Vishnu Vasantan, our resident, looked at some of our data. And this is a few years ago, certainly looking at our cardiopulmonary bypass, cross clamps, residual MR, and then our outcomes comparing to open versus minimally invasive, looking at our ICU length of stay of 1 day, hospital length of stay averaging around 5, reoperation for bleeding. So this is where minimally invasive makes a difference. So, the data I presented says safe procedure done through sternotomy, great operation, but where can we make gains when we're looking at minimally invasive surgery? Well, it's, less bleeding. So reoperation 0.9%. Typically, you'd be, in the range of 3 to 5% for sternotomy. So that's a big gain. Blood transfusion. With a sternotomy, you're looking at a blood transfusion rate. A lot of centers report 50-50. So 50% chance of transfusion. We're looking at like around 12%, inside 20% anyway. So there's where we look at the benefits. The benefits from minimally invasive valve surgery: less bleeding transfusion, shorter ICU hospital stay, fewer wound complications, smaller scarred. It does matter to a lot of patients, particularly younger women, or, fewer respiratory complications, less rhythm disturbances. And, what's so important to us is better post-op mobility and getting back to activities. So this is what we think minimally invasive surgery really benefits. And a patient recently wrote an article in CMAJ talking about his recovery. An active guy's a family doctor, and he felt, his recovery was really enhanced by a minimally invasive approach. And it's one thing to say that subjectively, but it's another thing to provide, data to show, is that really true? And I think, we've written articles to say it's this qualitative outcome, these patient-centered metrics that should guide us when we're talking about minimally invasive surgery. Corey's going to talk about that and the work we've been doing to sort of look at that in a minute. But just wanted to quickly touch on some of the other things we're offering in this center related to minimally invasive approaches for mitral valve. And this is a neocord procedure. This is kind of a niche procedure done for degenerative MR. These are patients that are maybe higher risk for conventional surgery. This is done on the beating heart, no cardiopulmonary bypass through the apex of the heart. Now, this is I'm gonna play this video, and I don't know if the audio is going to work. This is
in this video, we present minimally invasive off-pump mitral valve repair with the Neocord DS1000 system. This is an innovative device that implants multiple sets of Gore-Tex PTFE neocords onto the prolapsing segment of the posterior mitral valve leaflet. This hybrid operation is performed under TEE guidance and beating heart conditions. The patient in this video is a 75-year-old man who previously had minimally invasive mitral valve repair with a 36mm annuloplasty ring and 4 Gore-Tex neocords. On follow-up echoes, he had recurrent severe mitral regurgitation due to prolapsing of P2 and P1 segments. The operation was performed in a hybrid operating room, which allowed for projection of echo images easily visible to the entire surgical team. The patient was placed under general anesthesia and positioned supine. A 3 to 4 centimeter incision is made at the 5th intercostal space in the anterior axillary line after identifying the location of the left ventricular apex via transthoracic ultrasound. Soft tissues and ribs are retracted. TEE was used to appropriately guide AV apical access. Proline pledgeted sutures are placed around the apical access site for future snaring. Meanwhile, on the back table, the Neocord DS1000 device is prepared with loaded Gore-Tex sutures. The Neocord DS system is inserted through the LV apex and positioned across the mitral valve and into the left atrium, which is confirmed on echo. The prolapsing or flail posterior leaflet segment is grasped. This is evident on 2D and 3D echo images. Positioning of the grasper is confirmed using fiber optic feedback contained within the Neocord system. The sensors demonstrate adequate tissue in the grasper when 4 lights are illuminating white. When the device is deployed, the needle passes through the leaflet. The ends of the inserted Neocord are retracted out through the LV apex with the device. These ends are pulled taut and a loop forms on the free margin of the leaflet where the needle was inserted. Subsequent chordal insertions are performed as required to alleviate residual mitral regurgitation. Chordal tightening is performed under full loading conditions of the beating heart and with real-time echo guidance. The chordal tightening results in the retraction of the posterior leaflet towards the apex, moving the point of coaptation posteriorly. The cords are then fixed on the epicardial surface of the apex with one large single felt pledget and tied. Post-operative TEE shows trivial residual mitral regurgitation.
Okay, so I thought it was important to show you that. We're very proud of it. We're really the only training center for Neocord in North America, and we're the only center that's doing it in any significant volume. There are centers in Europe doing high volumes of that procedure, but we're the only one as a training center in North America now. Now, you have heard about this. Nish did a wonderful job, I think a few rounds ago, talking about our MitraClip team. Very proud of this, as Andrew said, to start out the collaboration that we've been able to enjoy with the MitraClip team, and Mike Curtis and Nish Sharma, Duke Hahn, Chris Persinkowitz, Svet and Jill on the echo side, and then down at the South Health campus, Stacy and Deb have just been, we've really formed a great team, and very proud of that, as you're aware. So as I mentioned, with Neocord, we've become a training center. We really want to work on becoming a trainer center of excellence. We want Calgary to be a destination for innovation and for learning. We want to disseminate cutting edge techniques like minimally invasive surgery, like Neocord, and transcatheter techniques, certainly. So we want to train other surgeons, and we continue to, a little bit more on this later, but we continue to focus on our national conference where we bring surgeons and cardiologists from centers across Canada every year to Calgary. We're establishing and working on a mixed research team with Jolene, has a lot of experience in the cardiovascular ICU. Kaylee Stevens is from University of Waterloo, recent grad from their master's program working in cardiovascular sciences. And we have to recognize Karen Weens and all the great work she's done on our rapid recovery protocol for minimally invasive surgery. So I'm going to turn it over to Corey. He's going to talk a little bit about that. Half the story is what happens in the OR, but the other half is really how you take care of patients afterwards and their outcomes. And the recovery protocol is an example of that.
Okay, so you've probably seen that our research team there. So Kaylee is with us now, came from Waterloo, so she's full-time with us, and Jolene is with our program, and Sam is here. And so we've now said we can do these things, but let's look at how we can do them better. So some of you guys have seen this rapid recovery protocol. So in combination with anesthesiology, with ICU, with nursing, with physio, we got a champion in each group, and we said, okay, we're going to do minimally invasive surgery, but how can we look at our outcomes and how can we improve? So the group created a rapid recovery protocol after minimally invasive surgery. So things that we did as surgeons and and nurse practitioners taking the lines out. We just automate it. We empower the nurses to do this. And then we said, okay, let's run a little trial where we say X number, we'll just start the program on this day, and then we'll see what our outcomes are. So looking at our outcomes, and this is a big deal for us that as we go through it. So every patient that undergoes minimally invasive is in a registry. Every patient that goes through, we can take the data from either Connect Care, we can take it from Approach, and we can independently look at our outcomes. So if you look at our outcomes, we just ran the protocol for 75. So 75 patients before, 75 patients after, and there was no real difference in any of these groups, and there shouldn't be. We just looked at what we could do. After instituting the protocol, for which we did very little, we looked at a composite outcome, which said how many patients were out of the ICU at one day, so about the same. How many were discharged less than equal on post-op day number 4, and what was our readmission rate? So we established safety, saying that more patients aren't getting readmitted. And we established that they can come out of the intensive care unit at the same time, there's no difference, but 20% more can go home on post-op day 4 without getting readmitted. So we looked at that and we thought, well, how can we get better? Well, we just asked the questions. Why were patients admitted? How many went home on post-op day 3? How many went on 4? How many went on 8? And then we looked at median days. We looked at why patients didn't go home, why patients didn't get extubated. So in the JTCVS paper, it'll have the relative risk for getting sent home, for why you didn't get sent home. But from our standpoint, we can achieve more patients being sent home on post-op day 3 at 17% compared to 7, and then more patients, 40%, 60% gone home on post-op day 4 compared to 40%. So that's in minimally invasive. That is not in full sternotomy. Looking at compliance there, we can get the chest tubes out on day 1, the pacer wires out on day 3. Physiotherapy signs off on half the patients by post-op day 3, meaning they could go home. So we know there's other forces that keep patients in the hospital, but we know about that on day 3, after a right minimally invasive repair, over 45% of your patients are cleared to go home. So in terms of when you consult a patient and when you're talking to your patient and you say, what's the recovery like? Well, you can go home in a cohort of patients who are 60 plus, around 50% will go home on day 3. So looking at the times, and we look at these, how many have pacemakers, acute kidney injury. So no deaths in our last 150. There hasn't been a death from a right minimally invasive mitral repair in, I think, 3 years. Pleural effusions, readmission rates are quite variable for patients that end up coming to hospital for any reason. So some do come back. Once we look at this, we said, okay, it's safe. Now, how much does it cost? So we look at health economic data. So we took our cohort of patients from Calgary and we said, well, let's go through Connect Care and pull the data of how they did with the sternotomy. The average ICU length of stay for a sternotomy in a patient with a degenerative mitral regurgitation done in this institution is 3.6 days. We compare it to both the fast track and the regular. This is not random. This is just registry, a patient who came in here who was sent for us. If we run that cost just based on the length of days in the ICU on 200 patients a year, if we didn't do minimally invasive here, so if we just did sternotomy-based surgery and did no minimally invasive, the average cost would be $6 million, just based on those 2 extra days. And that is from asking AHS to give us the data for this cohort of patients. Because we do minimally invasive, and the fast track was 1.9 and the regular was 2.2, we know it's going to save us money. So from a health economic standpoint, we made this argument. That's just in the ICU cost. If you look at the patients who were discharged home, the percentage of patients discharged home on day 4 for a sternotomy in this institution is 22%, which is pretty good. But the percentage of patients discharged home from fast track is 60%. And the regular right minimally invasive is 46%. So these are the 2 minimally invasives. And this is the sternotomy group in this institution. And the numbers aren't much different. You're talking about 40 in this group and 75 in these 2 groups. If we run that out and say, well, let's do better as a fast track group, which our physio and our ICU team felt that we could get that to 75%, what would be the cost savings? So if we just look at that, if we were to say fast track 2.0 discharges patients at 4 days, it'll cost $1 million. If we keep going the way we are, it'll be $7 million. That's if we run that out on 200 patients a year. So that's the yearly cost. Yet we still use those little rulers to expose the inside of the heart. So when we make arguments like this, we get a little passionate about it because we're like, look, we think we're saving money for the institution and we have good outcomes. So we think we have got one thing where we've got good outcomes that are equivalent to sternotomy. We think from a health economics standpoint, we're getting it. Now, I find health economics really hard. So we're working on these papers. They're not published yet, but we're in the process of working through them. So now basic science. So the team here with the Libin group has done a great job of looking at inflammation markers and just looking at the bare basic science. So one component of our research is basic science. So we have health economics, clinical data, and now pericardial. Take the pericardial fluid if someone has from a sternotomy, take the pericardial fluid from a right thoracotomy, and see about inflammatory markers, potentially leading to decreased admissions for things like Dressler syndrome, making the redo operation harder. So our minimally invasive patients do get basic science research. This is the point of this. In the post-operative pericardial space, and Ali can talk about it, there appears to be less inflammatory markers here. So we were pleased with that. So we have our patients in that, and we think because of decreased pericardial inflammation, potentially less adhesions, potentially less pain, and potentially less inflammation in postoperative atrial fibrillation, which we still have to work at. So we've gone to economics, we've gone clinical outcome. Now the new kind of world is patient-reported outcome measures. If we know we do a good job equal to sternotomy, well, how can we show that something better than mortality? Mortality, stroke, kidney failure, we think they're the same, but let's actually look at how the patients themselves feel. So if we take, this is aortic valve patients, those 16 patients, we know it's small because this is in a registry, and we take these patients, they're in a registry, they get their surgery, their data is inputted at the time of surgery, and then it just, our graphs change. Okay, so our graphs are updated by Kaylee all the time. So when someone gets surgery, they go into the database and the graph changes. So this is just 16 patients full sternotomy, 13 patients with a minimally invasive right thoracotomy. And yes, the minimally invasive patients are a little bit older, but we'll just look. We don't call the patients because we find that patients don't really tell us the truth. They'll say, yeah, I feel fantastic. It's probably better if a nurse calls them or if your researcher calls them and says, how do you feel? So we take the validated scoring scales and we say, well, tell us your baseline quality of life. Where are you at 2 weeks? So in minimally invasive, what we are seeing is a very high percentage of patients compared to full sternotomy feel better at 2 weeks. At 6 weeks, it's not a lot of difference. And you would start to expect that. The minimally invasive should do better earlier and it should equal out longer. And that's what you'll see in the transcatheter valve population. The patients just do better. This is a great help from some of the researchers at Libin and guys, we put every patient into this. So the EQ5 score, we want to see every single patient that undergoes surgery. Where are they at 2 weeks? They get a phone call, 4 weeks, 6 weeks, 12 weeks. And then more importantly, we like to track the ones who aren't better. So why did this person not get better? And this is the aortic valve population here. I'll show you the same one in the mitral valve population. But in the aortic population from a right anterior thoracotomy, 80% of the patients are saying at 2 weeks, I feel better. So that's not bad. We're okay with that. So we're encouraged by that, saying that a patient is reporting feeling better. They might not be perfect and they're not claiming to be perfect, but we're trying to see why. Then we break this down into individual groups. Is it the pain? Well, pain is there for sure, but doesn't appear to be a huge issue. Is it coughing? Are they back to walking? Is it chest wall pain? Is it sleep disturbances? So we try and really split this into groups. And we have to split it into aortic valve and full sternotomy, and then we split it into mitral valves. So we do the same thing for the mitral valve cohort. So different study, same questions, different study. This was the randomized UK mini mitral trial, which said at 12 weeks, you had a sternotomy for 100 mitral valve repairs and a right minimally invasive, there was no difference. And a lot of people said, well, if there's no difference in terms of stroke, death, or how patients feel, then just do a sternotomy. Well, 12 weeks we feel pretty strong is too far out. So at 12 weeks, everybody should be good, or the majority should be good. That's not where the benefit of minimally invasive comes in. The benefit of minimally invasive comes back early. So here's the minimally invasive cohort. So we look at where are they at 3 days post-op? Well, they're not going to be better. That's not what they are. The mitral clip population that we have is in this study, and we're going to look at where the mitral clip patients feel better. Do they feel better at 3 days? Are they better at discharge? Again, if you look at 6 weeks, 96% of them feel better. Mobility, patients are mobile. So we think our patients peak out and are back to good mobility at 6 weeks, which is encouraging. Same thing with pain and discomfort. The ICU team has done a fantastic job with pain and recovery. When we track these patients at who hasn't gotten better, interestingly, atrial fibrillation is one of the devils. If the patient is in AFib, they don't feel better. Now, I mean, that's probably not a rocket thing for most cardiologists here, but for surgeons, we're not addressing that from a minimally invasive. So in order for us to achieve better in minimally invasive, we either have to get them out of AFib or treat the AFib at the time of surgery. So we have to figure out some way to do something probably with AFib. So as we move through this, we're trying to now tell people, and I agree with, it's kind of a theme as, I mean, I came here 5 years ago and I knew a lot about Calgary, but not to know you had 2,000 cases, and not to know that we have a strong interventional cardiology program, you have a strong EP program. I think we just got to continue to tell the world what we do. And this is where programs come in habit. So Jolene's work with being a program development, creating the website, raising awareness of what we do. The conference that we run is 100 people per year. This will be its 3rd year. We show videos. We have a lot of discussions from international people that we've had come talk with us. We had the head of Leipzig last year. So they're at 4,000 cases. We've had guys from Northwestern, from UC Davis, and we continue to do that. And so our plan is to continue to grow it. This is an information package that your patients are now going to get. This is written for minimally invasive. So it talks about minimally invasive atrial septal defect. It'll talk about tumors, when you can smoke again, when you can drive again. All the things are in there. So we're trying to get a better book because we get all those questions and you get all those questions. So we're trying to liaise on them. When can I drive seems to be the big thing these days. So we're trying to put those CCS guidelines in there. So we're trying to do this. So our biggest thing now that we're really proud of, and with Mike and Nish here and everybody else, is where are we going to go in the next 3 years? So we've done this presentation to the Healthcare Foundation, and we have partnered with the Healthcare Foundation, and we now have a 3-year multi-million-dollar commitment towards mitral valve and tricuspid valve interventions. So we are very excited about this, and we package this to the Healthcare Foundation by saying, okay, we have expert imaging people. Do we have people that spend, we have the civets, we have new recruits, we're going to use this to market people and bring people in. So the Healthcare Foundation bought into this, and we talked about how are we going to do this. So the first thing they wanted was an established multidisciplinary clinic, so a disease-specific clinic. So we have nurse practitioners down at the South Campus who will see these complex patients, and you can refer directly there. Every patient gets timed up and go. They get a MOCA score. We check their neurological, we check their quality of life, and we get them in, they're all in the study. So we're going to track these patient-reported outcomes and the hard outcomes and the health economic outcomes and some basic science. We're committed towards a transcatheter tricuspid intervention. We're with the Abbott group now that that's FDA approved. We're hoping to get somewhere in the fall 2024. That's going to take time. We've got to go together as a group to get the training, but we've talked to Abbott about how we're going to do this, where we're going to do this. The beauty of it is the funding is there from the Healthcare Foundation. So we're going to make a plan for that. Mitral, the transapical and the transcatheter interventions, the same idea. So talking about going down Tendyne, we've talked to those group. We're talking about which valve we're going to pick. It's very tough to ask Alberta Health Services for that money because it's just a different drive. But this money with Calgary Health Foundation combined with Alberta Health Services will allow us to explore different types of valves. So while we don't have it now, we're in the process of doing that. And Abbott's been good. The companies have been good with talking with us. And we're all just in the process of trying to figure out which valve we want to do, how we want to do the team, but they're expensive. They're 35 to 45,000, and we got to figure out which way we want to do them and how the team is going to do it. So between the 4 like implanters, the 2 to 3 imaging people, the nurse practitioners, we're all trying to make a plan to how to do this properly. The key is for us to have a program, and that seemed to be the emphasis from AHS and from Calgary Health Foundation. They were willing to fund a program dedicated to this. So you can't just dabble in aortic surgery and then dabble in mitral. We got to commit to all aspects of this. So all aspects of the whole, all aspects include health economics, include basic science and translational work. So as a group of surgeons with the interventional cardiologists, with the implanters, with the nurses, with physio, with research, we do aim to lead the world, or at least definitely North America. And I think we can do this quite easily, because we seem to work well together. There's common sense, people are honest. And I think we can not just do it in Southern Alberta, but across the country and across the world. And I don't think we should sell ourselves short, and we should continue to push. So I think that's it from the research and our idea, but we're open to comments and to talk about how to improve.
We will open it up for questions, both online. I'll open up the chat. If anyone wants to type in, or you can just speak up on the chat and in the room. Any questions in the room off the bat?
Well, I'll just make a comment. Thanks for sharing all this. I knew little bits of it, but it's nice to kind of see it all together, and very impressive. You're looking at various aspects, right? Not just the clinical, the economics and basic science. And also I know your, payment is set up that you don't really have protected time for this. So it's really impressive that you're able to get so much. Thanks for using the ruler.
You haven't applied for the real.
Catherine?
Comments, first a non-serious comment, but you need to change a couple of your slides. There's no blue sky.
Yeah, true.
But you need to fix that. But what I didn't understand was the pericardial fluid and what the inflammation that you're seeing in the pericardial fluid in the non-invasive versus the invasive approach. So when do you take that fluid? Why should that be different?
Well, yeah, Ali's right beside you. He did all the work.
Why do you think I asked it?
You want to take that one, Ali?
Sure. Thanks. So all these patients were enrolled prospectively, both the conventional and all got the antibiotic they usually give us. Straight away, cleansed it. What we think with what's happening with the extent of your pericarditis is much smaller. Anecdotally, we've seen that post-op these patients have fewer inflammatory response that happens with surgery is a lot more work that we need to do. The next
I can understand that part, but if you're taking the fluid right off the bat for both, why should?
Well, there's also, so with the sternotomy, we have to go through the chest. Muscles underneath, all that elicits very quickly, and that's the thing that a lot of these patients that response. You don't have to cut through bone and very.
The other thing, Ali, is, you collected a time point after surgery. So a lot of these inflammatory mediators are, we went 4 days out.
So the data that Dr. Ken and Dr. Adams presented here was taken 4 hours after pump, and then inflammatory markers in that space post-op. That's what the difference is.
Catherine, does correlate with how much bleeding there's. Significantly less bleeding in minimally invasive. That's part of the reason, less inflammation from less bleeding inside the pericardial space. And then maybe it's all that inflammation that leads to the AFib that we see. That's why there's a trend, certainly, in all these case series. It's less AFib after minimally invasive surgery relative to sternotomy. This might be part of it.
That's my next question, is the atrial fib. Are these patients generally, when you look at both groups, are the same number in percentage in atrial fib prior?
Yes. Exactly.
And size of atrium?
That we didn't look at yet, but I think the same number are in AFib before surgery that go for surgery then the rate's lower after. So we think we might have a signal.
But that's a good point. We've got to include size of atrium. I'm sure it's the same, but that's a good point. I think.
Brian had a quick question. Brian Hars was, are there any ways we can advocate for Alberta Health to fund procedures such as neocord mitral clip and tricuspid clip? Well, we try that, Brian, and it's a partnership, I think. So Alberta Health Services, we've gone to Libin, we've gone with Alberta Health Services to Amanda, we've gone to surgical initiatives. And yeah, there are ways to do it and we push for it. We just don't want to be the center that was sort of like one off. And so like just does one center and the first in the world. So we just don't want to be, oh, we put one valve in, first in the world, never do it again. So what we're really working on, Brian, is try to get that partnership. So that was what drove us to go to the Calgary Health Foundation. Then they partnered with the group at Alberta Health Services and said, okay, if we give this amount, you guys match this amount, here's your 3-year period. But like that comes with that comes with very strict rules. So we have very strict rules, like at 3 months, we have how many patients came to clinic, who saw them in clinic, what were the outcomes in clinic, what were the patients that were seen, what were your results like? So when we partnered with Alberta Health Services and Calgary Foundation to create this program over the next 3 years for NeoClip, MitraClip, TriClip, and percutaneous mitral intervention, we had to write all that out and say, okay, here's the champion of interventional cardiology. Mike Curtis is going to do this. Nish is going to do this. Imaging is going to do that. So it's hard. Advocating is for sure, but we're trying to we tried to advocate and show all this money, but now we're pushing more for, okay, how can we partner to do this? And different groups are giving different money at different times. So I think we're lucky to have this 3-year block. Hopefully it comes with more after 3 years, but that's where we are. It's hard.
Yeah, I mean, I think it's an important point is that part of the funding from Calgary Health Foundation was to say, sort of, AHS, are you going to support afterwards? And they're really supportive, so.
Yeah, and like timely fashion, like AHS's comments to us, like we pushed as hard as we could, and there were things like, well, we have to offer timely cardiac surgery, timely interventional procedures. Is our role really to know what the latest neocord innovation is at 40,000? Is that AHS's job, or is that a different job? And I can sort of see where they were coming from there. So we're lucky to get some of these innovations and not just 1 to 10 procedures. It's an actual program to try and lower it. So we have set rules for who gets a neocord, who's going to get a clip. We're still struggling and trying to get better. But that's why we have different personalities there. Someone will say, no way, that's a bad idea. This is a good idea. The nurses help out. Mike stops us from doing stuff that's that's out there, different questions. And I think from the referral base of all cardiologists, it's important to say, hey, can you advocate for this patient, or what intervention do you think is the most appropriate? So the disease-specific clinic is also helpful.
Just a sort of practical question following on from some of Catherine's points about AFib. I'm just wondering what's your left atrial access point when you're doing the minimally invasive right-sided approach? Are you going through the right atrium and the septum, or are you going posterior wall? Just in terms of where there's going to be scar in the left atrium, which may be relevant for future.
Yeah, good point. That is one of my videos, but that was too long, so I didn't include it. But yeah, it's right through the right superior pulmonary vein.
Okay.
Almost through the vein.
Yeah.
And then extended down a little bit inferiorly.
Right. So with that, the trials that we didn't mention is left atrial appendage occlusion.
Yeah.
So we just got approval we're in the trial, the LEAPS trial. So we'll take off the left atrial appendage with AtriCure with a clip through sternotomy, and it's paid for and covered. So when we take it off, we enroll the patient in the trial. It's a really simple procedure to take off. We're pretty sure we get a good result on it. Now, can we do that with minimally invasive? There is a special clip. It costs more money. We're working out how to get that. First, we'll do the sternotomy ones, then we'll figure that out. The maze procedure, a full, the correct maze with left and right. We went to the course. We're looking at how to do it with minimally invasive. We know it's going to add time to the procedure. So we're trying to figure out the literature. Should we do left and right? Should we just do left? Can we just start with left? What are the ways to do it? So we're in talks with it, but we want a program.
Both of those things are funding issues, but the clip is something that we need to do that.
Yeah.
And getting in the LEAPS trial, that's the most important trial in cardiac surgery right now, I think. And so we're pretty happy with part of that. So left atrial appendage ligation in patients at risk for AFib versus not. And we all know that there's a huge stroke difference between those that are in AFib. So that may extend to patients at risk for. So we're part of that, and the company is going to support us with clips to put the appendage on all these cases. We don't have funding for the clip outside of that trial, which is unfortunate. We're still working on that, but it's a step.
Yeah.
For sure.
And for the AFib, we need a program. Like, our thoughts are, well, we just don't want to do the procedure and not follow the patient. So once we get certain programs here, we would say, okay, our atrial fibrillation wing, all patients are on X drugs, followed at X time, just slide in with our researcher and we can see them. So once we go down that road, but we could do a left thoracotomy video assisted atrial clip now without having to open the breastbone, right? We could come into the camera. So there's things we're trying to get into that world.
Can you get access to the left atrial appendage from the right side?
Yeah.
Yes.
You can get
Yeah,
around
transverse.
the front.
Transverse.
Right underneath the aorta.
Right underneath the aorta, yeah.
Kristen.
First of all, excellent talk. I really enjoyed that. This is more like a process question for right now. So I think you guys have done a very good job at advertising this program, because I've had, even in the past few weeks, mitral valve patients who have mitral valve prolapse and I think could have repair, they want a minimally invasive repair. They're asking for it, right? And so what I have been doing, right or wrong, is referring to a surgeon that I know does that. But from a surgical group, or say someone's coming in for mitral valve repair, are you guys looking at all those patients and then deciding if they'd be appropriate for minimally invasive? Like, does everyone get to be considered for that, whether they ask for it or not? And if someone does ask for it, will they get it if technically feasible, is my question.
Yeah, that's a really good question. So most of the time, yes, they do. Then there's also, well, so somebody comes in, needs to be emergently done. With scheduling, we can only do minimally invasive surgery certain times of the week because we don't have enough equipment to run 2 rooms. There's new one to do it. And so then, those patients, no, they don't. So sort of an urgent, emergent situation, not necessarily, but a more elective or, semi-urgent inpatient.
Yeah, like if we did, I think last year we did something like 220 mitrals or 240. So if 180 went to minimally invasive between Bill and I, most do. So probably 90% or 85%. We get along. So we'll, like if one of us is away or someone's got a ventricle that's down, we'll say, listen, I'm going out of town. This is a ventricle that needs to be done. Do you mind doing this? And we sort of trade them back. And so we're pretty easy going on that to try and triage them. Like the triage is 12 weeks for an elective for according to the ACAT score. If we can make it, if someone's in heart failure, well, then we make it 6. If they're in the hospital, it's 2. So we try and triage them that way, but 12 weeks can be a long time for your patients. And if you think they're unwell, just tell us and we'll make them 6. And then we try and get more time. We're limited by only doing, we can only run one room a day. So we're probably doing 5 days a week of a mitral valve surgery, but we'd like to do both of us operating the same day. So one of us does mix one day and then the other one can't for a mitral because we don't have enough supplies. If we had more supplies, we'd do more cases.
But part of it as well, though, is the goal would be for those referrals to go to the mitral valve clinic, not to go to an individual surgeon.
That's what we're
Right, and then so then they get assessed by surgeons and interventionalists, and that appropriate triage and placement of that is rather than going to an individual surgeon who may have a bias.
Yeah, that's what we want.
Yes.
That's what we want.
Very good point.
Yeah.
And that's especially, right,
Yeah.
and that's especially
what
important
we
as we have these other interventions, like as one of those last slides showed, the evoke valve for the tricuspid and the tendine for mitral. So, figuring out what patient's right for what intervention is going to be more and more important. MitraClip versus transcatheter versus surgery, minimally invasive. That decision making is important, particularly for mitral valve.
Yeah.
And
Like I would say one of the examples would be, so we had someone who's like 88, and we look at them for clip. Well, they're a bad anatomical candidate for clip. They're deemed like yellow or red. Okay, they're not good. So then they see the nurse practitioner. Well, you know what? They're active. They live by themselves. They're fit. They could undergo a surgery. They're neurologically okay. Okay, so that goes to a right mini. Meanwhile, you see a, say, 75-year-old, 70-year-old who's perfect, would be a green case, who's had other issues in the past. They could go to clip or go to neocord. So if we've got everybody weighing in, then we make a better decision as opposed to shortest wait list or next available, right? That's our goal.
yeah, no, that's.
And I agree with Mike.
Yeah.
I'd like to go back to SCAR a little bit. And those neocords, that looked like a honking big tube that went into the.
Yes,
Yes. That's
And you're tying all of those cords on epicardial.
Yeah.
So what about ventricular activity after all of this sort of thing?
Yeah, we haven't seen, so I don't know what our
In the
AFib rate.
case, there's a lot.
They're in the case of a lot. Yeah. So we have done now, I think it's 14 or 16, and we have them all followed. Rates of AFib after surgery, I don't think are anything different, but it's a big hole with no catheter for which you just pinch and put the device right in. It's a 14 French, basically.
And you tie those cords on the epicardial side after.
Yeah.
We sure do, yeah. And we hope they hold. But we follow them, right? So we follow them with echoes. We push to get, and one of the areas of research that we want to get into is imaging, but we don't do it. So we'd love to see more, CT scans or the MRIs of these patients, right? We see the echoes, we see the durability of the repair and how the patient does, but seeing if we've created a giant scar or how much of an infarct we did, like, there's no question there's an infarct, right? It goes right through the muscle.
But it is a single stab wound with an 11 blade. And so, it is small incision, but I mean, I don't know how many French that device is. It's big.
Yeah,
Right.
it's big.
You
But
can
it's,
see.
we would say though that of the first when we did 10, we had to do an evaluation. There was 8 of them that went home or 7 of them that went home on the next day or the day after. So the business of saying the thoracotomy is not great. Well, these are different patients. They may not be the peripheral arterial disease patients that we saw in the TAVI world. They're different than the transapial excluded other issue. They had a good apex that was lined up and we went in there. So they go home on day 3, day 4. We didn't have very many readmissions. We had one fail. And that's all part of the process of learning.
Art to the position of the neocord on the apex, for the
Yes.
architecture.
Yeah. Well, there's a whole lot of art about where you're supposed to come in on lateral, you come under, and if there's that much tension on the cord or how much it's going to come straight and when it's going to come in, and you're moving it, you're listening to the echocardiographer. They're saying a little more lateral, a little more medial, and we're just moving our hand a little bit. Then you open up the jaws, squeeze it, look on the lights, good. And then we move it off and then we move it back. So there is a lot of art to that procedure that we're still trying to figure out, but it's fun. I mean, we enjoy it.
Are they anticoagulants? It's post-procedure, or what's the
Yeah.
prothrombotic risk?
Yeah,
of this?
we give them heparin intra-op,
But they don't
not
go
full dose like cardiopulmonary bypass, and afterwards we reverse it.
Yeah, and we just give them a little aspirin, like there's no anticoagulation for that. There's no annuloplasty on there. And so the cords are in place. No one else is gonna do it, so.
Be any clot on the cords.
We haven't,
No.
no.
Svet here online. Can I just,
Go ahead, Seth.
thanks for a great talk, guys. Really exciting program and great to see the full spectrum of the work that you're doing. One of my questions is a bit about where you see the role of neocord versus clip, because it seems like both procedures are well suited to address central valve pathology like P2, flail, or prolapse segments. So how do you, what in your minds, like, do you see a distinction between how these two technologies might work and which patient might be better suited to one versus the other?
Yeah, that's a really good question, Svet. And I think, neocord is a small niche. Neocord can't address annular dilation. And so if you have a dilated annulus, it's not going to be optimal. So I think there's not, the majority of patients with degenerative disease do have a dilated annulus. You got to look for the ones that aren't. And as you know, clip can provide some of that. So, clip can provide a bit of an annuloplasty effect. Neocord can't. So I think neocord, its application to patients with degenerative and MR and functional MR, much greater. And, I think neocord is just a subset of.
Yeah, I would say specifics. I think MitraClip is limited when you have an annuloplasty in place. It's hard to bring that MitraClip across there. Neocord is perfect for that. So a redo recurrent MR after a previous repair, I think is excellent for neocord. And when we get those yellow cases and we say, oh, it's going to be 3 or 4 clips, or there's a lot of cases, neocord might address that if the annulus isn't big, because we can put a cord in one part of P1, we can put it over on P3, and there's no clip there. And then if we got to go back and repair that valve, it's not an automatic replacement. We can keep those cords in. So if you take somebody who's young, and we say, okay, let's try this neocord, well, we can go right minimally invasive thoracotomy and repair that valve after. So I think it's different patients, but the redos for sure we can benefit from. And the cases that are yellow or red, maybe, depending on the reasons why they're yellow or red. But there's a distinct role for both. Maybe 10% neocord, we think.
Yeah.
Yeah, just to piggyback off that, I think you guys have done a great job of getting this program initiated and really on the ground running. So kudos to both of you. But to just piggyback off what Svet said, I also think as we develop the program, you can use other repair techniques to complement each other. In the absence of an annuloplasty ring, similar to our failed neocord case. And I presented that in Toronto just this last weekend and with a really good reception. So these individual repair techniques will sometimes overlap, I assume, over time to complement each other. So that's one of the other benefits of having kind of a comprehensive program with multiple options.
Totally. I think that's where we are. Like where we are now is we've got it where we can for surgery, but we need other allied people to help us, right? We need to say, okay, we need more opinion about the transcatheter. We need to learn more about other edge-to-edge, annuloplasty transcatheter devices, more imaging help, more clinical help. So we've gotten it here. Now to get that disease-specific clinic further, we need to recruit more or have more people join us or push more. Right?
On that, and I think we're top of the hour. Thank you very much. That was nice. Sure.
So I'm gonna